All right, moving on to our next exemplar of inflammation, acute pancreatitis. So acute pancreatitis is a reversible process that is caused by inflammation of the pancreas. Now, this inflammation can be caused from a number of different reasons, which we'll get into. But what really happens with this inflammation is that the pancreatic enzymes auto-digest and eat up the pancreas itself, which can cause a lot of pain for these patients. Now, remember that the pancreas is responsible for producing insulin, which helps with glucose regulation. And it also helps with digestive enzymes, producing digestive enzymes that we need for digestion. So both of those processes are messed up when the patient has a pancreatitis. So the pancreas is connected very closely to the bile duct. And so one of the causes of acute pancreatitis is gallstones. And so when those gallstones occlude the bile duct and near the pancreatic duct, then the pancreas is not able to release its digestive organs into the intestines. And when that happens, those digestive secretions get backed up into the pancreas, causing this auto-digestion of the pancreas itself. So you'll see that the pancreatic and the bile duct openings are very close. Now, alcoholism accounts for about a third of the cases of acute pancreatitis. So patients who have chronic alcohol abuse and are binge drinkers will often come in with acute pancreatitis symptoms. Now, because alcoholism is more associated with men than women, we're going to see alcohol-induced pancreatitis more commonly in our male population. The gallstone-induced pancreatitis is more common in women, as gallstones are more common in women in general. So what are we going to see in these patients with acute pancreatitis? Well, we're going to see left upper quadrant epigastric pain. Epigastric means really at the top of your stomach, or top of your abdomen rather, on the left side. And that pain can be described as deep or sharp. And it can be more intense when eating fatty foods, because when you eat those foods, the pancreas is triggered to release more of those enzymes. And those enzymes can't go anywhere, so the pancreas is getting eaten alive by those pancreatic enzymes. The patient may complain of abdominal fullness, gas or bloating, indigestion or hiccups. They may have a fever, not because they have an infection, but due to the inflammatory process. We also may see them have tachycardia, an increased heart rate, and hypotension, a low blood pressure. Now, in terms of medical diagnosis, on physical exam, the abdominal cavity is going to be very tender to palpation. And there can be some rebound tenderness, meaning when you palpate or press on the left upper quadrant of the abdomen, it's not when you press that it causes pain, but it's when you let go that the patient experiences pain. That's called rebound tenderness. Now, on physical exam, you may also notice the Cullen sign, which is a bruising around the umbilicus, around the belly button, or the Graves-Turner sign, which is flank bruising, so along the back side on the one side. And both of those are indicative of interabdominal bleeding and hemorrhage, which can be caused by the pancreas getting eaten alive. Laboratory tests, there's a good table for you to notice on page 1399 of different tests that we're going to see. Specifically, I want to point out amylase and lipase. Now, amylase is a pancreatic enzyme that helps with digestion, and lipase, digestion of carbohydrates, I should say, and then lipase is a pancreatic enzyme that helps with the digestion of fats. And so both of those, we may see a spike or an elevation when someone has acute pancreatitis. So if you've never seen this before, patients with acute pancreatitis are miserable. It is an incredibly painful experience for them. So how do we treat it? Well, we know that this is reversible and short-lived. So we need to keep them NPO, so nothing per mouth. Why? Because we don't want them to have the pancreas release more digestive enzymes. So if we keep their gut quiet, the pancreas won't be triggered to release those enzymes. We're going to give them IV fluids to make sure we maintain a good fluid volume status. And sometimes these patients can have severe cases of acute pancreatitis where other organs like the heart, the liver, the lungs are impacted negatively, the kidneys. And if those other organs are starting to get impacted, those patients will need to go to the ICU. And really what we're looking for is treating that underlying cause of the pancreatitis, like if there's a gallstone. And so if we can identify the cause and treat that, then hopefully we can reverse it. Now, there are a number of different medications that we can provide patients for acute pancreatitis. This is going to be found on page 1400 of your text in table 60.3. Things like opioid analgesics, morphine, or hydromorphone, those strong opioid controlled substances that can help provide relief from strong pain. Now, remember, these are controlled CNS depressant, and so you'll want to check their respiration rate before you give these. Well, hello there, future self here. Listen, as I was editing this video, I realized that I made a mistake on the types of opioids I recommended. So opioids are recommended for pancreatitis, both for acute and for chronic. But morphine and dilaudid hydromorphone actually cause spasms at the sphincter of Oddi and are not indicated for pancreatitis. The sphincter of Oddi is this muscle right around the end of where the common bile duct and the pancreatic duct meet. And that if we give the patient morphine, it's going to cause spasms there, which is just going to increase their pain. So Demerol or meperidine is the appropriate opioid of choice for patients with pancreatitis. And now, back to our regularly scheduled program. Anticholinergics and spasmodics can help decrease the motility of the gut, which can provide relief. Histamine blockers decrease gastric acid secretion. Pancreatic enzymes can help that patients can eat when they consume food so that they do have those digestive enzymes in their gut, which can help them with digestion. And then antibiotic therapy, if indicated, for those times that there is an infection present. Now, a scary complication of acute pancreatitis is necrotizing pancreatitis. Necrotizing means it's eating through the pancreas and actually eating into the abdominal cavity itself, which can cause a mortality of about 30 to 50% of the patients who have this. Patients with necrotizing pancreatitis will need to be seen in the ICU and often will go through a surgical procedure to have part of that pancreas removed. As always, let's go ahead and talk through the nursing process as it comes to acute pancreatitis. When we're thinking about assessment, these are the kinds of things you'll be looking for. Patients will present with sudden onset acute abdominal pain. They'll have an elevated heart rate and respiratory rate and a low blood pressure. They'll be experiencing significant pain, sometimes with that rebound tenderness in the left upper quadrant. You're going to see on their labs those elevated pancreatic enzymes like lipase and amylase. And we'll also see problems with glucose regulation because remember, the pancreas helps with digestive enzymes and it also produces and regulates insulin. We can see hypocalcemia and we can see clay-colored stools. Now, when it comes to assessment and analysis, we can look for hypovolemia, low fluid volume, hypoxia, low oxygen levels, problems with their lungs, acute respiratory distress syndrome, and multiple organ dysfunction, meaning many of their organs can have damage, including their kidneys, their liver, their heart, or their lungs. So our nursing diagnoses for acute pancreatitis are going to include acute pain, ineffective breathing pattern, and imbalanced nutrition less than the body requires. Because remember, every time patients with acute pancreatitis eat, those pancreatic digestive enzymes are released, which causes increased pain in the pancreas. So those patients are often going to have anorexia and be less than inclined to eat an adequate diet. All right, our interventions. We're going to talk about our assessments, our actions, and our teaching. In terms of assessments, we're going to be watching their vital signs, their oxygen status. We're going to be doing a full pain assessment. Where is it located? How intense is it? How long does it last? When did it start? Does it come and go, or is it constant? We're going to do our abdominal assessment with palpation and observation. Auscultating those bowel sounds. We're going to look for those Gray, Turner's, and Cullen signs. And then we're going to look at their labs, specifically at those pancreatic enzymes, lipase and amylase, which are pancreatic enzymes that help digest fat and carbohydrates. We're also going to look at their serum glucose because remember, the pancreas regulates insulin. We're going to look for serum calcium because insulin and calcium go hand in hand and you can have low calcium levels. We can look at their stool color. We're going to notice clay-colored stool. We're going to monitor their nutritional intake, their daily weight, and their intake and output. how are we going to take action on these patients? We're going to maintain NPO status, keep that pancreas chill and keep it from releasing more of those digestive enzymes. We may need to put them on an NG tube to low intermittent suction. And we're going to administer the medications as ordered, things like analgesics for pain, antiemetics for the nausea, histamine blockers to reduce stomach acid, and sedative and anti-anxiety medications as indicated. Remember, these patients have significant pain, which can be very anxiety provoking. And so all of these medications together are going to help provide relief as the patient gets through this acute episode. We're also going to promote bed rest in semi-Fowler's position or fetal position for comfort, and encouraging coughing and deep breathing. The abdomen and the chest are so close that patients are hesitant often to take those deep breaths. And without taking nice deep breaths regularly, they can result in atelectasis or pneumonia because they're not getting those deep breaths down into their lungs. What are we going to teach them? Well, we're going to teach them an appropriate diet, low fat, and to intake small, frequent meals, and also include vitamin supplements. Avoid alcohol, especially if that was the trigger for the acute pancreatitis, as it is for about a third of the patients with acute pancreatitis. Avoid smoking, and then what to watch for in terms of disease symptoms, the progression, diagnostic procedures that the patient might be going for, making sure they understand what that is and why they're doing it. And also always explaining to the patients what interventions you're doing, if you're starting an IV, providing medications, making sure the patients are understanding what's going on and in agreement with the plan. How do we know if we did a good job? What are we going to watch for? We're going to see stable vital signs, stable weight. Their electrolytes are going to maintain in normal limits. We're going to see a decrease in pain from the patient reporting their pain status. And we're going to see those liver enzymes decrease and those pancreatic enzymes, lipase and amylase, decrease and come back to normal levels. Those are going to tell you that you did the right thing in helping to get this patient through this acute pancreatitis. And on the flip side, remember, patients can progress and see end organ failure. So you're going to watch for your patients to make sure they're not getting worse and that you're not seeing their kidneys starting to fail and their creatinine and BUN, and that we're not seeing worsening vital signs. Anything like that may trigger a need to be headed to the ICU for further care. And that's going to wrap it up for acute pancreatitis. We will catch chronic pancreatitis as a separate video. So I'll see you soon.